Hi, folks. My name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, genitourinary health, and men's health. And I have board-certified urologist Dr. Brian Steixner here with me today. Brian, say hello to the crew.
Thanks for having me, Amy. It's a pleasure to be here.
It's so good to be able to talk with you today. We actually have known each other, at least vaguely, for many years. We both graduated from the University of Pennsylvania for a urology residency. And then we kind of met up maybe like when I was in my residency, you were already out. I think we were talking about like some research initiatives. But I think that was my first foray into how curious and creative you are. And then here we are.
Thank you.
So welcome, folks, to our Urology Times recording today. We are going to be talking about premature ejaculation, which I don't know of a single urologist who gets excited about this conversation, but I think that Brian is going to be able to add some excitement to this topic today. So, Brian, why don't we just start off? Why don't you give us a brief introduction here? Talk about a little bit of your path to urology, your current clinical practice, and also, perhaps, most importantly, when it comes to the topic of today's discussion, your role with Popstar Labs and your interest in product innovation.
Yeah, thanks for having me. Like you said, we both trained at the University of Pennsylvania. I finished my residency about 15 years ago. Following training, I went into private practice. I currently am the chief of urology for a large community hospital on the East Coast. And I'm also the co-founder and CEO of Popstar Labs, which is a urologist-founded sexual wellness brand that's focused on bringing real solutions to patients that are rooted in science, but also focus on maximizing confidence and pleasure in the bedroom.
So let me ask you a follow-up question here. Why is it important that the company is founded by urologists?
I found my practice focuses on sexual wellness and sexual medicine. And the one thing I noticed years ago was a lot of the solutions that people were finding on the internet at 2 a.m. were not rooted in science, and sometimes they were even unsafe. And so as the company developed, my co-founder, Josh Gonzalez, who is also a sexual medicine doctor on the West Coast in Los Angeles, he and I were looking for real solutions that were safe and effective for patients that we could present to them or offer to them in our practices. That's the origin of the company, and it's grown from there.
And what's your interest in premature ejaculation?
Well, it's funny when you said get excited about it. I said we should have dampened excitement for premature ejaculation because that's the whole conversation here. Premature ejaculation is one of those things that is not talked about a lot. But what we know in sexual medicine is it's the number one sexual medicine complaint that exists in men today. And so from that standpoint, it's a huge opportunity to help patients. And so when we looked at what we could do, both as a clinician and also as a founder, premature ejaculation stood out, right? Because what solutions are out there? And as any practicing urologist knows, it's one of those complaints that they see on their list of patients that they're sort of terrified of because they don't know what to do. And so we were looking to really understand the science behind premature ejaculation, understand the landscape of what is out there and what available for patients, and then come up with a solution that we could stand behind or we could offer both in the clinic and as a consumer.
And when it comes to this condition for premature ejaculation, depending on which definition you're looking at, the guidance will say when a man has an orgasm within 1 to 2 minutes of being in a vagina. How do you define premature ejaculation for the purposes of your treatments?
It seems like there should be a simple answer to that question, right? Like if you can't last long enough, you have premature ejaculation. But the more you learn about premature ejaculation, the more complex it gets. There are really 4 types of premature ejaculation, right? From primary premature ejaculation, which means it's been a lifelong problem, to secondary premature ejaculation, which is it is acquired. And so when I see people who have acquired premature ejaculation, think things like hyperthyroidism or diabetes or high blood pressure or contributing factors such as other medical conditions. There are 2 other subtypes of variable type of premature ejaculation, and people who have perceived. They don't really fit the same category as the first 2, as most of these people have a normal, some variable PE is kind of normal for men, and perceived means that they can last long enough, but they think they have a problem. So for the nature of this conversation, we're talking about primary and secondary. How do you define it? The first time premature ejaculation was discussed in the late 1800s, it was defined as not lasting long enough for your partner to reach orgasm more than half of the time, right? And that's probably the last time we thought about the partner in this equation. It was the late 1800s. And so the AUA defines it as not lasting long enough and it causing stress, which is an incredibly broad term. Fortunately, the ISSM defines premature ejaculation as either for a lifelong of not lasting up to a minute or acquired not lasting up to 3 minutes, with the caveat being that it has to cause stress and be a permanent or continuous problem. And so in my practice, I talk to people about if you've have a lifelong problem and you can't last in the vagina for up to a minute, you probably have primary ED. And if this came out a second time and it's lasting less than 3 minutes, then you probably have secondary ED. Now, it's also put.
Wait, I just want to, so primary and secondary PE, right?
PE. Yes, I'm sorry.
ED. Yeah.
I'm sorry. Yeah, I speak PE and ED. It is important to point out what the norms are, right? And so there's a study from the Journal of Sexual Medicine from 2005 that says that the normal intravaginal latency time is somewhere around 5.5 minutes. And interestingly, in that study, we actually found that younger men last longer. So men in 18 to 30 lasted 6.5 minutes. Men in their middle ages, I like to think of them as young, but men 30 to 50 lasted around 5.5 minutes. And older men actually lasted less than 4.5 minutes. And so when we talk about these numbers, lasting less than a minute, lasting less than 3 minutes, it's important to know what the norm is considered. In that data, we also found that less than 25% of men can last longer than 10 minutes.
That's really interesting. I've never seen that data before. Interestingly, in my patient population, I feel like I see a lot of older men that have delayed ejaculation.
Yeah, in fact, there was a New York Times article about it about a week or two ago. It is one of those rising things that we're seeing, whether or not that's related to health issues like diabetes, high blood pressure, whether or not that's related to the overuse or use of SSRIs in our community. We are seeing that delayed ejaculation is growing. And you would expect men as they get older to have longer lasting time if they're in monogamous relationships. But yeah, it's definitely becoming an increasing issue in the sexual medicine space.
So let me ask you this question. Do your patients actually know how long they're lasting? Because definitions are based on time. Like when I've asked my patients, they don't really have a great sense.
No, they don't. When we talk about intravaginal latency time, we use it as from an academic standpoint for research purposes and to have conversations where we're talking about the same thing. In my practice, when people come in, a lot of it is perceived, I can't last long enough. And I don't ask how long you can last a lot of guys. I mean, sometimes I'm trying to tease out whether or not this is a new issue for them or a lifetime issue, or if it happens all the time or just sometimes, so I can help come up with a solution. But if you come into my practice and you have lifetime ED and you can last 2 minutes, I still treat you like you have premature ejaculation.
Yeah, I think sometimes we get hung up on like the actual diagnosis and all the numbers and all the nuances, but I am totally in agreement with you. If someone's coming in wants to last longer, all of these therapies that we're going to discuss are all still fair game. All right, so let's talk about some of the misconceptions related to premature ejaculation. And we have a lot of urologists that are watching. When I think back to my training, I don't know that I ever really learned about premature ejaculation, despite the fact that we went to an Ivy League institution to learn our urology, training. I remember in fellowship, when I did a sexual medicine fellowship, I saw like a handful of patients who had premature ejaculation. I remember handing them, my fellowship director had a printout for a delay spray that I could just say, hey, why don't you try this? It's over the counter. I didn't provide any guidance on how to use it because I didn't really know what tips and tricks to provide. And I don't think I really offered anything else. And then going into when I was on faculty at an academic center, I saw some guys with PE and would talk about SSRIs. I think I probably prescribed it once or twice, but it wasn't really a big part of our training. What do you think some misconceptions are for our fellow urologists when it comes to this disease process?
Yeah, I agree with you. I don't think we talked about premature ejaculation once in residency. I think we saw it on the in-service exam, and there was one question. You just had to pick the SSRI. So I agree with you. And I also think a lot of urologists aren't excited to see these patients. There's not a lot they can do. It's a complicated subject. There's no surgery involved. For me, the biggest misconception and something incredibly unique about premature ejaculation is that it's evolutionarily advanced, right? You see men come into your practice who have low testosterone, right? They want high testosterone because we have societal norms, we have normal levels, and there's a reason to have a testosterone level that is normal or high normal. You see men with ED, right? There's a reason why you have an erection so that you can reproduce, right? And so having ED is a problem. Premature ejaculation is unique in the sense that the quicker you orgasm, the more likely you are to reproduce. And that's the goal here, right? And so lasting 10 minutes, 20 minutes, 2 hours actually is against evolution. And so for a lot of my patients, one of the most disarming conversations you can have is to sit down with them and say, congrats, you are actually advanced, right? If we went back 500 years, you would survive and not get attacked while having sexual intercourse. And so it's an interesting way to reframe this conversation to men who are incredibly anxious and incredibly stressed to make sure they understand that perhaps there isn't anything wrong. And that as humans, having sex for pleasure, that poses the problem. And so that's where you start the conversation about solutions to help them be better, more confident, but that there's actually nothing wrong.
I love that. Do you actually say that to patients?
Every single time I see someone with premature ejaculation, it is the first thing that I say because it disarms an incredibly stressful conversation.
Mm-hmm. It's so interesting because, as I see men of all ages, this definition of what is pathologic when it comes to the amount of time it takes to climax varies so greatly, right? We know a lot of people that would love to be able to last an hour, 2 hours when they're younger. And then when it takes them 1 or 2 hours when they're 7 years old, they don't have the stamina or let's say like the interest to keep up for that long. So then it becomes pathologic. And then we say they have delayed ejaculation. So I think our definition, even for someone who's been lasting the same period of time their entire lives, evolves, right?
Yeah, for sure. It's funny you bring that up. It's an incredibly private subject, right? And we know there are issues with erectile dysfunction are clear. We can measure those. We know that if you don't have an erection that lasts long enough is strong enough for penetration or lasts long enough for maintaining sex, that it's a problem. But when it comes to sort of these subjective things, it is quite variable, and perception a lot of time is based upon societal norms. And we're seeing a lot of access to information, access to pornography nowadays, and it's changing the perception of norm. And so when you have these conversations with patients about premature ejaculation or delayed ejaculation, a lot of times it's a moving target.
Quick question here. Is that your favorite topic to discuss, ejaculation?
So, the one thing I'm passionate about is sexual medicine, right? When I was in training in medical school, we talked about the decade of the heart and the decade of the brain. And it always seemed like sexual medicine was ignored. And in training, especially at the University of Pennsylvania, where we were oncologically focused and all we did was prostatectomies, we neglected, or I thought there was a neglect of the post-erection issues that would happen. And so I became interested in sexual medicine as a surrogate or how it relates to oncology. And so that empowered me to look critically at all aspects of sexual medicine and to look for real solutions. And so when we launched this brand, Dr. Gonzalez and I really wanted to make sure our clinical solutions were something we could present at grand rounds at an academic institution. And some of the supplements that we have, we're incredibly proud of. But we're most proud of our delay spray at this point because it's our first opportunity to interact with academic urologists or practicing urologists and to offer a solution that is developed by urologists, controlled by urologists, tested by urologists. And so I'm passionate about it because it opens up my opportunity to interact with urologists, which is what I like to do.
Love that. So now let's get into some of the solutions. So let's say you have a guy in your clinic who's coming in with premature ejaculation or just wants to last longer. What are the different things you're going to talk to him about?
Yeah, I look at the treatment landscape for premature ejaculation as acute and chronic, right? A lot of times guys are coming into your practice and they have done an infinite amount of research. They've talked to their friends. They've been on chat groups or Reddit. They've looked everywhere for some solutions, and they've tried a lot. You'd be surprised how much information these patients actually have, more than you would expect. And sometimes they actually know more about premature ejaculation than the average urologist for some cases. I talk to them about two different things. First, that there's a long-term solution that we need to work towards, right? And so there's a lot of things that we need to do that will hopefully fix this problem for them. I also talk to them about the acute situation, right? So it's almost like a pre-workout and something you would take during sex or during working out. And so the acute situation are on-demand treatment options or things that they can do in the moment that will make them last longer, right? But the chronic things are long-term solutions, things that they can do in the day-to-day that actually get them long-term growth. And so those are the two conversations I have with everyone, and I think they need to work in concert in order for someone to get a real solution.
So what I'm hearing from you is there's not one single treatment option that you recommend. It's really maybe some combination therapy that gives the best results.
Yeah, I don't think I have a single patient who I don't discuss some form of combination therapy. And that starts with some of the long-term things that people have to do, right? And so any practicing sexual medicine doctor will tell you that they rely very heavily on sex therapists. A lot of these patients come to you with a lot of anxiety. They may have had one relationship, one interaction, one very stressful situation. Someone may have said something to them that crippled them and has continued to cripple them. And so that long-term solution to really correcting premature ejaculation always in my practice involves sex therapy. Very similarly, from a long-term solution, I talk about pelvic floor physical therapy. I, as well as most urologists in a growing population, love pelvic floor physical therapy. And it's not just the post-prostatectomy incontinence patient. It's not just the woman with stress incontinence. Pelvic floor physical therapy is the future of sexual medicine in a lot of ways. I don't know about your practice, but I love my pelvic floor physical therapist.
I love my pelvic physical therapist. I tell my patients if there's one type of provider that I routinely send my patients to, when my patients come back and they say, this person changed my life, it is the pelvic physical therapist.
I completely agree. The confusing thing that I struggle with now is I use pelvic floor physical therapy, and most urologists have heard of Kegel exercises, right? You strengthen the pelvic floor. It can prevent leakage. It can help with erections. And what we know is that strengthening the pelvic floor will allow a man, when he reaches that, quote, point of no return, to delay ejaculation for a little bit longer. The problem is there's some conflicting information as to whether or not, as you strengthen the pelvic floor, you actually increase sensitivity and shorten the time to ejaculation. So you can prevent it, but you're actually causing a worsening of the premature ejaculation. So my pelvic floor physical therapist that I work with right now really hones in on what the problem is, because a lot of men benefit from reverse Kegel exercises or pelvic floor relaxation to help them last longer. It's not a matter of preventing it when they actually get to that point. So a structured approach to lasting longer and then being able to delay it versus being able to delay it when that moment arises. There's some nuance to that, but a good pelvic floor physical therapist can help that patient work through that.
Oh, yeah, I second that completely. I think everyone's kind of looking for, okay, should I just do, Kegel exercises? And I'm like, no, the pelvic floor is very complex. I actually do recommend seeing, someone for personalized interventions there. Now, do you have a sense for how many visits it might typically take someone to, let's say, meet with a sex therapist or a pelvic physical therapist to notice benefit? That's where sometimes I have some trouble, especially with a sex therapist. I cannot think of a single one of my patients that wouldn't benefit from seeing a sex therapist, even if they don't have any problems. Why not, right? But the time commitment can sometimes be a little bit challenging. There's one that I work with in the local area in Miami who has a specific protocol. It's like she has like every session outlined in terms of how she would treat someone for premature ejaculation. I find that some people need sort of like an endpoint. It's like, how many sessions might this take? Do you have any sense on that for both the physical therapist and the sex therapist?
I would say that my approach is one is the most critical. At least one appointment from a sex therapist and a pelvic floor physical therapist to learn the basics. I'm a big proponent of telemedicine in the sexual therapy space because I think that commitment to the time commitment can be a problem. Also, a lot of urologists practicing in the United States don't have access to a sex therapist very close to where they practice. And so being able to see that therapist on telemedicine or on the phone or speak to them is important. I think that this is also a lifelong commitment, right? So there's two extremes to this. If you see a pelvic floor physical therapist, if you see a sex therapist, that initial encounter, that initial education, that initial unpacking of what's going on is absolutely critical. And more is more, in my opinion. If you see a sex therapist or a counselor for the rest of your life, there is only benefit from that, right? But sometimes it's not possible. When it comes to pelvic floor physical therapy, learning and training is no different than going to the gym every day. I mean, if you go to the gym once and you feel great about it, you're going to feel great every single time you go. The more you do it, the better you'll get, the stronger you'll get, the more muscle training you'll get. I do think YouTube has been critical in the form of pelvic floor physical therapy because going and learning the correct exercises, which can be difficult to isolate and has been statistically shown to difficult to conceptualize on your own, doing biofeedback, actually seeing these muscles work, trains you for success in the long term. And I think that can be done at home, both at the table when you're having dinner. I always say do your Kegels when you pick up a fork. It always means you're doing them 3 times a day. But I think YouTube can give you the ability to continue to do these on your own time. And so I think it's paramount to see a sex therapist once. I think it's incredibly important to see a physical therapist once. I think the more you see, the sky's the limit for the benefits that you can get from both of them.
Are there any other interventions that you recommend to address sort of like this chronic issue lifelong? Do you recommend like masturbation trainers? My Hixel out of Spain has one. Tenga out of Japan has another product. Anything there that you recommend device-wise?
Yeah, I mean, cost is always an issue with these. But I think as a society, we are becoming very reliant on data, which I love. I think data is a weapon and data can empower you. And so I love any access to data so that people can see success, right? We know the psychology behind it. If think about Instagram, if you get a like, that positive feedback, that dopamine response, if you're using my Hixel and you're training yourself and that for those who don't know, this is a premature ejaculation trainer that you insert the penis in. It can warm, it can grip, it can increase friction, and it will give you app feedback onto how well you're doing. And we know that works. I mean, that works for us when we use our apps on our phones for various other reasons. And so it can only work for a psychology behind this. So yeah, I'm a big fan of data-driven metrics. Cost tends to be the issue that prevents people from getting these.
What I like about the MyHixel device is people can use it in the comfort of their home. And it combines the training device with cognitive behavioral therapy. So that's where I see if someone is not really interested in, let's say, seeing a sex therapist, because that's where I more so might see issues with like costs is a lot of them are like out of pocket. So if you look at it long term, then perhaps buying a MyHixel for a couple $100s and then using the CBT in combination with it could lead to cost savings down the line. But it allows, we're not taught how to do cognitive behavioral therapy. We don't have the expertise and we don't have the time in our clinics to do it. So I think it's always interesting to use these technologies that kind of allow us to provide that sort of like mental health training without us actually having to train the person. So I think it's very interesting technology. Is there anything else in terms of like treating this patient lifelong chronically that you feel like is helpful when it comes to interventions?
No, those are the big ones.
Okay.
I mean, I think those are the big ones that I work with: pelvic floor physical therapy, sex therapy. And then I move on to some of the acute things that we can do medically. And that's where I think that we have the biggest impact as urologists.
Yeah. So let's delve right into that. Where do you begin?
Yeah. When I was first practicing, I would go right to a medicine, right? It's how we practice as a whole. And so I'd see a patient on my schedule with premature ejaculation, and the first thing would be in my mind is, I'm going to write this guy an SSRI, right? That's how I practice. I think that's largely how a lot of urologists practice nowadays in the community and in academics who aren't focused on sexual medicine. My practice has changed over the past 10 years. I start slower, right? And so the first thing I offer most guys is some way or some mechanism to decrease sensation during intercourse, right? You assume these patients are all going to do sex therapy and work through any issues they have. They're all going to be doing pelvic floor physical therapy or reverse Kegels to get the pelvic floor trained the way they need to. In the moment, How do we make them last long, right? And so the first thing I go to is condoms, right? It's always been condoms. As a urologist, condoms are a slam dunk, right? Because A, we're preventing unwanted pregnancy. B, we're preventing STIs. And 3, if you put a thick condom on, you can last longer. The biggest obstacle that I find is some people don't like condoms, right? And I get a reflexive trigger back that, yeah, that's great. I think it makes sense on a lot of levels, but I don't want to do it, right? And so for the patient who is open to using condoms, the thicker the condom, the better. And encouraging that only serves to benefit your patient. And so that's usually where I start. For the patient who doesn't want to do that, or the patient who needs more, the next thing I go to is delay sprays, right? And so delay sprays are analgesics applied to the penis that are designed to decrease sensation and last longer. And I will use these solo for the men who don't like condoms. I will use them together with condoms to even have a synergistic effect. And so delay sprays and condoms are usually the first line of therapy as a urologist that I'll use.
Now, there are a lot of different delay sprays that are currently on the market. They're available over the counter. Like, why did you specifically decide to delve into this space when there are currently products on the market? And how is it similar and maybe different from currently available products?
Yeah. When it comes to delay sprays, when I talk to patients, there's some critical differences, right? The first is, are you using bupivacaine or are you using lidocaine, right? And the reason why they matter is because they pharmacologically are different. Bupivacaine takes longer to be absorbed. It is longer lasting and has a better absorptive pattern on mucosa, right? When you compare that to lidocaine, which is quicker absorbing, which is shorter lasting in a way which is positive for these men, and also has a better absorptive pattern on skin. And so when I talk patients about delay sprays, the first thing I say is like, what are our goals here, right? Because if you're in the moment and you're applying a delay spray and you know that sexual intercourse is going to happen in the next 15 minutes, you don't have the time for bupivacaine to work. In addition, you're spraying it on the head, the frenulum, and the skin of the penis, and so you want maximum absorption. Now, the other thing is, we're talking about patients who on average can last 1 to 3 minutes, right? So if you put lidocaine on there, you want to be able to get them to last longer, but also not blunt or prevent orgasm. And so using a lidocaine-based spray applied to the frenulum, applied to the head of the penis, applied to the shaft, can increase their intravaginal latency time, but not prevent them from having meaningful sexual activity and actually having a enjoyable orgasm.
So would it ever make sense to apply both lidocaine and bupivacaine?
I don't. I typically do not, because what I find is that the lidocaine actually will be absorbed the most and the bupivacaine will compete with that. And so I'm primarily using a lidocaine-based spray.
Now, what about, because you mentioned that bupivacaine gets better absorption on mucosa.
Yeah.
What about applying bupivacaine to the glands and lidocaine to the shaft? I'm just curious here.
Yeah, we could nerd out on it and make the perfect combination. I think there's a stress factor for these patients when they're applying it and they're in the moment. And so they're just trying to get some solution. The other thing we didn't talk about is the percent absorption, right? And so what strength lidocaine are you using? Because the products on the market are quite variable, right? There's stuff that's 1% lidocaine. There's stuff that's up to 10% lidocaine. And so we need to figure out both the percent, but also recognize when you're talking about how much you use, are you using too much volume, right? Because there comes a point in which you can't get any more of this material or this product onto the penis. It's just left in excess. And so it doesn't get actually used as wasted material. And so I'm a big fan of lidocaine-based solutions applied to the head, frenulum, and the shaft in 10% lidocaine, which is the strongest on the market, which allows you to get the maximum absorption without the risk of transfer to the partner.
So I'm going to take a big risk here, and I'm going to speak on behalf of a lot of urology colleagues to say, I don't think any of us know any of this information or how to differentiate what you're telling us now and how different products are variable in terms of what actual medication they contain.
Yeah, I would agree. In fact, when I was working with my company with Popstar, a lot of this science was new to me. And a lot of the information that I obtained was not from the urology literature. It was not from the sexual medicine literature. It was actually not even from the sex therapy or psychiatry literature. A lot of the science behind this is extrapolated from the biologic literature surrounding tattoo artists. And so what we know is that there's a blossoming amount of science that is related to how you numb the skin for certain amount of times related to tattoos, and how nicks in the skin relate to absorption, how you can titrate these doses. And so when we were developing our lidocaine spray, not only were we looking at the premature ejaculation literature and studying it, but it's tough to get an IRB for this stuff, right? So there's not a lot of literature out there about intravaginal latency time or penetration. These are difficult studies to recruit for, to get approval for, to get funded, and also to study. And so the tattoo world is exquisitely good at stratifying time of numbing and lasting. And they tell you they can titrate a lidocaine dose for 1 minute, for 10 minutes, for 8 hours.
Well, it's fascinating. I didn't know that tattoo artists use lidocaine. I've had some patients that have had tattoos, and I feel like it's part of that process that they kind of suffer through it when they're getting a tattoo. But good to know that some tattoo artists out there are using anesthetic.
I don't have a tattoo, and I didn't know that either. But when you are trying to be creative and find new solutions, a lot of times it leads you down different pathways. And so, I always think about, Raphael Carrion down in Florida, and some of him is extrapolating some data with orthopedic casting when he's doing implants and stuff like that. And so I'm always watching what others are doing in the scientific world and the medical world, but also in the biologic spaces. I mean, reading papers out of Nature and Science, you learn a lot that can be extrapolated into urology because the physiology is the same.
So you mentioned some of the challenges of studying this, formulation in men. So how does your company define success, and kind of how are you measuring that with people who try your product?
Yeah. When it comes to delay spray, a lot of our data is subjective, right? We use a lot of the current literature. We do subjective data. We make solutions. We are FDA, certified. We try and make our solutions so they are made in America, they're approved, they're urology tested, and then we allow patients to try them and bring it back their results and let us know exactly what their responses are. And then we evolve and evolve and evolve until we get to a place where we're happy with the formulation, we're happy with the outcomes, we're happy with the delivery system, the safety profile. And one of the big reasons why we did it is, as a sexual medicine doctor, you'll appreciate people will take a lot of different things that they will buy on the internet, right? You see in the ED world, you see it with people used to order their Cialis and their Viagra from overseas before it was off patent. And we see the same thing in the topical lidocaine space, right? You can order a lot of these things. You don't always know what you're getting. Some can be caustic. Some people can have burns. Some people can have permanent nerve damage. And so when we saw that, we recognized that having a solution that is born out of real sexual medicine doctors, that is tested, that is reliable and safe, puts together a lot of variables for patients and makes us feel more comfortable with what they're using, and also makes the patient feel more comfortable.
So what have patients told you? What are some of the good things? What are some of the bad things? And how has that how has that inspired your product evolution?
Yeah, I mean, when it comes to the delay spray, we're seeing a huge success with delay sprays. Something that we always saw with delay sprays in sexual medicine, something that I saw in my practice. I was always a big believer in delay sprays. With our delay spray, we're seeing increase in lasting time, which is primarily the thing that we use as a measure of success. But the one thing we're seeing that we're actually most satisfied about, going back to what we said about that definition of premature ejaculation in the late 1800s, we're actually seeing partner orgasm rates double, right? And so that is incredibly critical for us. The other thing is, we are aware that in the sexual medicine space, we serve all communities. And so we speak of this term intravaginal latency time as a surrogate. And a lot of the data is purely based on heterosexual relationships. And so one of the things that our product is focused on is supporting the LGBTQ community as well. And so Josh and I put a lot of effort into supporting that community. And we're actually looking at intra-anal latency times or self-pleasure latency times, things that are often very important to our patients, that we don't ask about. We may make assumptions that everyone's in a heterosexual monogamous relationship. They are not all in that situation. And so making sure we're looking to the exact thing that our patient is looking for and how do we achieve success in that. In fact, early on when we were talking about the LGBT community, the intralatency time anally actually was associated with pain in the receptive person in the bottom. And so having a spray that actually could transfer may have been beneficial in that situation, albeit not beneficial for the vagina. And so there is a lot of nuance to this, which a lot of sexual medicine doctors will appreciate, but the average urologist probably wouldn't think about.
That's interesting. So do you have a different product when it comes to anal sex?
No, we don't. But we actually are seeing a lot of our gay patients use it as a analgesic for receptive anal sex. Yeah, because it does numb it up, especially people who are new to that or new to bottoming. They'll find that it actually increases their ability to be successful.
Oh, that's very interesting. And obviously also relevant to heterosexual couples who engage in anal sex. So you have a very interesting sort of like day-to-day in your life as CEO and co-founder of Popstar Labs, and you run a division of urology. So like, what does a typical day look like for you as an entrepreneur and, like a business owner and a busy urologist?
Yeah, I mean, I'm probably very similar to most urologists. I'm largely clinical. It's why I do it. It's why the company exists as well. I see patients every day. I operate 1 day a week. It's on the evenings and the weekends that I focus on Popstar and the brand. My practice probably reflects a lot of sexual medicine doctors. I see patients in the office 4 days a week, and I operate 1 day a week. And then I have a team. Josh and I have a team at Popstar that largely handles the day-to-day running of the business, and we primarily focus on research, development, ideas, and making sure that the company leads with education and awareness, right? So as we deliver information, whether or not that's social media or a blog or an interview or a podcast, we want to make sure that the company is always rooted in science and is supportive to communities and is sex positive.
So I want to kind of wrap up this podcast, really speaking to and addressing our urology colleagues who are listening. What is your message to our urology colleagues? One, when it comes to, hey, if someone watching is interested in starting a company and using their creativity to create something to help either people in sexual medicine or another space within healthcare, any advice that you can give them?
Yeah, go for it. I would say to you that as physicians, we are educated, we are intelligent, and we're in tune to what patients need. And when you're in tune to what patients need, you're being served opportunities to help first, right? And it is when there's a demand for a solution that the best businesses are born. And as you apply your scientific knowledge and your commitment to care and your commitment to excellence, that's where we have the largest ability in our lifetime to have the biggest impact, right? So when I was a resident in the lab, I was told something that made me think twice. And it was by a researcher. And he said to me, you can go back to the OR and in your lifetime, you'll help 10,000 people, right? But if I figure something out that changes the landscape of medicine in my research lab, I can affect millions, right? And so I still practice medicine because I love seeing patients and I love helping those couples or that person reach their maximal potential, get the success they need, get a solution to a real medical issue. But our ability to really impact the masses exists if we bring something to market that makes a difference.
I love that. I love every word you just said. All right. So the last question that I want to ask you, because we're always, as urologists, we're always closing, right? We're always looking for an exit strategy. We run busy clinical practices. We may only have 5, 10, 15 minutes to spend in the room with a patient. So what are the details that urologists who might be recommending the delay spray by Popstar, what should they be telling their patients? Give me like the 30-second elevator pitch so that patients actually know how to use this spray and can optimize how long they last.
Yeah, I think
Timing you.
I think the important thing is that premature ejaculation is something that is going to take several different things to help, right? And a lifetime of commitment to sex therapy and pelvic floor physical therapy is absolutely paramount. Now, in the moment, no matter how many Kegels you did, it's tough not to get excited and it's tough to delay ejaculation. And so when you're in that moment, you want to make sure that you're doing everything you can to maximize lasting time, maintain the sensation of orgasm, please your partner, and establish a positive sex environment, confidence. And so using a delay spray that is developed by urologists, that is tested, that is the strongest on the market, is going to give you the best chance of success without the concern that you're going to have a side effect or something's going to happen from something you ordered from someplace that you don't know. And so for me, it has always been about providing real solutions to the person or the patient who needs it. And so when those patients are in front of you, I think it should be part of a multidisciplinary approach to premature ejaculation.
Now, I said that was my last question, but I have one more question because these details truly do matter. How many sprays should someone tell their patient to start with? How might they titrate up or down? Where exactly do they apply it? How long in advance of sexual activity should they apply it? And should they be using it by themselves before they're with their partner?
Yeah, it's a lot of questions. So I would say to you, look for premature ejaculation sprays that are lidocaine based, that are 10%. I think that's important because I think the lower the dose or the lower percent you use, the more you'll have to use, which from a pragmatic standpoint is just more expensive. And also there's not always a lot of real estate. And so I recommend that all men do this. Let's say it's the night. It's Friday night. You just got home from dinner with your partner and you think you're going to be intimate and you're concerned. Slip into the bathroom, right, before anything happens and apply 1 to 2 sprays to the head and the frenulum and an additional third spray to the shaft. Allow that to dry. You may need to rub it in a little bit, but allow it to dry and give it at least 10 to 15 minutes, right? That 10 to 15 minutes doesn't have to be standing in front of the mirror watching your watch, right? You can go back out and do foreplay and do everything else that you would do, but then you know when the moment is right, you are primed for success. Whether or not you do it with your partner, I always say that the partners who are in this together get the best success, right? I say that with the patients who come in with erectile dysfunction who may need an implant. Having their partner there is going to help them with success. I feel the same way about premature ejaculation. That supportive partner from a psychological standpoint, from a mental standpoint, is critical. I mean, we know that the act of ejaculation is physical and mental, right? Those things combine at the level of the brain, the central nervous system, and lead to ejaculation. It's why SSRIs are used. And so having a partner there who's supportive can disarm a lot of that anxiety, a lot of that physical and mental concern together. And so, yeah, if you can have your partner do it with you, make it fun.
And then do you need to wipe it off at all?
They do recommend that you wipe off any excess. The reason why is you don't want to transfer to your partner. It's important for vaginal sex. It's also important for oral sex. We have had situations where people have absorption into the mucosa and they get numbing of the mouth. And so you want to be careful with that. But if you wait 10 to 15 minutes and you're using a 10% lidocaine spray and you're applying 1, 2, 3 sprays to start, it usually is not an issue. You can go up as high as 10 sprays. But again, if you're getting to that level, there may be some other things that we need to do.
Okay, follow-up question. When you say apply 1 spray to the shaft, where on the shaft? Or you just put 1 spray and you rub it all over?
Yeah, I mean, I typically say the further out, the better, right? And so from a sensation standpoint, for these men, a lot of the nerve are most isolated in the foreskin and the frenulum and the head of the penis. As you get towards the base of the penis, again, that's not as much involved in sensation of intercourse because during the act of intercourse, it's not in the vagina for the amount of time. So further out is better. But yeah, rub it in anywhere.
And then last question. So when you say, yes, you might want to rub it off, are you saying like a washcloth that has water on it? Or are you saying like some tissue or like toilet paper and just wiping off excess?
Yeah, I usually just recommend they use a towel that could be in the bathroom that they're in and wipe off any excess, but I don't want you to wipe off everything or be aggressive or use water. I want you to just wipe off any excess that may be there in liquid form. The rest should be dry, absorb, and it shouldn't even be noticeable.
Can the partner taste it?
Well, so another interesting aspect of what we developed. And so, yes, a lot of the products on the market had a medicinal smell to them. So they could be tasted, they could be smelled, and it was a problem for a lot of guys. And so Popstar's delay spray actually doesn't have a taste or smell to it, which is a big issue and a big upside for a lot of patients.
Oh, I'm glad you brought that up. Excellent. Well, thank you so much for joining me today to talk all things premature ejaculation. For so many years, and certainly it still is, ED, it sort of became popular and a lot of sexual medicine specialists were talking about it. Then, Peyronie's disease was very unpopular. And then all of a sudden with, I think, pharmaceuticals really doing disease state awareness, now everyone's talking about PD. I think premature ejaculation, I think this is the time for PE. I think this is the SMSNA is now saying that like ejaculatory disorders are really top of mind in terms of supporting research initiatives. I think the next few years, PE, time to shine.
Yeah, and we know that. I mean, we didn't talk a lot about SSRIs. There are ones that aren't available in the United States that are shorter acting that patients really are asking for. And right now there's a couple medicines in the third phase of clinical trials that are short acting, premature ejaculation focused SSRIs, SNRIs. So the landscape of premature ejaculation is evolving, and I think that's most beneficial to our patients.
Awesome. Well, hashtag let's go. So where can people find out more information about you, your practice, and your company, Popstar?
Yeah, I mean, we're online, popstarlabs.com. That's primarily where we sell our products out of. I'm excited that we may be available on menmd.com pretty soon. I know a lot of urologists in the sexual medicine space use that. And we are on Amazon as well.
Awesome. Thanks, Brian.
Thank you.